Whoops, wait a minute. I moved it. There you go.
Good afternoon. This is Alan Sousie, Director of Nursing at TLC Home Care, and we are presenting today information concerning a very significant problem among elders. It's called Parkinson's disease and Parkinsonism. Those two ideas are slightly different, and I'll explain as I go through my presentation the differences. The sources of this information is the Parkinson's Disease Foundation online resources and Parkinson's Disease, a complete guide for patients and families, the third edition, which was produced by Dr. W.J. Weiner, Dr. L.M. Schulman, and Dr. A.E. Lang at Johns Hopkins University. Parkinson's disease is a chronic and progressive movement disorder, meaning that symptoms continue and worsen over time. Nearly 1 million people in the United States are living with Parkinson's disease. The cause is unknown, and although there is presently no cure, there are treatment options such as medication and surgery to manage symptoms. Parkinson's involves the malfunction and death of vital nerve cells in the brain, called neurons. Parkinson's primarily affects neurons in an area of the brain called the substantia nigra. Some of these dying neurons produce dopamine, which is a chemical that sends messages to the part of the brain that controls our movement and our coordination. As Parkinson's disease progresses, the amount of dopamine produced in the brain decreases, leaving a person unable to control movement normally. The specific group of symptoms that an individual experiences varies from person to person. A person could have this disease for several years before motor symptoms even become obvious. Some of the early symptoms of Parkinson's are decreased sense of smell, stiffness in the joints, constipation, mood change, and sleep disturbances. It is extremely premature and practically impossible to make a diagnosis of Parkinson's disease based on these early symptoms alone. As you can see from the list, there are many other illnesses that contain these as symptoms. In addition, accurate observation of affected motor function is vital for a valid diagnosis because there is no other method to screen for Parkinson's disease. Primary motor signs of Parkinson's disease include the following: tremor of the hands, arms, legs, jaw, and face; bradykinesia, which is slowness of movement; rigidity or stiffness of limbs and trunk; and postural instability, or impaired balance and coordination. Parkinson's disease presents very gradually. In fact, currently the disease is not usually diagnosable until 50 to 70% of the cells that produce dopamine have died. Parkinson's disease primarily affects older people. Some of the symptoms, such as rigidity and bradykinesia, can manifest themselves in other neuromotor disorders. And in fact, about 20% of those initially diagnosed with Parkinson's disease may actually have another condition. Symptoms that mimic those of Parkinson's disease are called Parkinsonism. The term Parkinsonism is a generic descriptive term that refers to the whole category of neurologic diseases that cause slowness of movement. The category includes classic Parkinson's disease, atypical variants like multiple system atrophy, progressive palsy, and Lewy body dementia, which are sometimes called Parkinson's plus syndromes, and any other brain disease that resembles Parkinson's, such as hydrocephalus or drug-induced Parkinsonism. For a significant minority, about 15% of all persons with Parkinsonism, one or more of the typical variants are present, and the neuromotor dysfunctions more serious and less treatable. Let me take a few minutes and provide you with brief information about these variants to help edify your knowledge of Parkinsonism in general. I will begin with multiple system atrophy, MSA. MSA, multiple system atrophy, was formerly classified as 3 separate diseases: Shy-Drager syndrome, striatonigral degeneration, and olivo-pontocerebellar degeneration. Now, taken collectively as MSA, which is a whole lot easier to say, The variant may include these following symptoms: ineffective autonomic nervous system function, which contributes to the control of your urinary continence, sexual erection, and blood pressure responses, to name a few. It also includes impairment of the cerebellum of the brain, which demonstrates as being clumsy, having slurred speech, and gait disorder, which are slightly different from classic Parkinson's disease. It's quite challenging to separate MSA and Parkinson's disease without extensive diagnostic testing. It's important to do so, however, in order to properly treat the Parkinson's effectively. Another atypical variant of Parkinson's disease is progressive supranuclear palsy. It has the same motor symptoms as Parkinson's disease, however. In PSP, that is progressive supranuclear palsy, gait and balance are the primary difficulties, and they appear earlier than in classic Parkinson's disease. Usually in classic Parkinson's disease, falls do not occur until late stages of the disease. In PSP, also, it presents with problematic eye movements, which often causes an affected person to bump into furniture and other objects, which increases their risk for falling. On the other hand, in PSP, tremors are less challenging than they are in Parkinson's disease. So last and not least, PSP responds well to the typical medication used for treatment of Parkinson's disease symptoms, but unfortunately, they lose effectiveness very quickly. A third variant of Parkinsonism is Lewy body dementia. Lewy bodies are proteins in the body. Proteins are usually folded in special shapes. And some proteins, if they are not folded correctly or become crumpled due to some cellular problem, stick together in clumps. Similar to how clumps of the protein tau are a hallmark of Alzheimer's disease, clumps of protein called alpha-synuclein are the hallmark by which Parkinson's disease is also diagnosed. These alpha-synuclein clumps are also known as Lewy bodies. Parkinson's researchers have long noted what appears to be the spread of Lewy bodies from one brain region to another. Researchers observed possible clinical evidence that Parkinson's could spread from one cell to another when fetal stem cells were transplanted into the brains of people with Parkinson's disease. The transplants subsequently developed Lewy body disease. That is, something about a Parkinson's brain made genetically unrelated cells that were only a few years old developed the signs of Parkinson's disease. What came out of these observations was the controversial idea that Parkinson's, once started, might be transmissible from one brain cell to another brain cell. And potentially, what does this mean medically? Well, it brings hope that a Parkinson's therapy might be found in one of the two ways, using special antibodies that target Lewy body, or a vaccine, which primes the immune system to target Lewy bodies. Either approach may not only halt the spread of Parkinson's disease, it might even prevent it. Another cause of confusion between Parkinson's disease and Parkinsonism may result from certain types of medication. A common drug category of culprits is the neuroleptics. Neuroleptics are tranquilizers commonly used to treat schizophrenics and some psychotic behaving people. These tranquilizers block the distribution of dopamine from the brain throughout the rest of the body. And consequently, after using them for long periods of time, an individual will begin to exhibit rigidity, slowness of movement, and other symptoms of Parkinsonism. In true Parkinson's disease, such symptoms occur very gradually over years, whereas in drug-induced Parkinsonism, the symptoms appear within 2 to 4 months. A second distinguishing feature of drug-induced Parkinsonism is that motor dysfunction usually appears initially in all 4 extremities. Classic PD typically demonstrates symptomatically on one side of the body. Last but not least, drug-induced Parkinsonism, unlike true Parkinson's disease, can only be effectively resolved in 6 to 12 months after removing a medication causing the symptoms. This is best practice when treating drug-induced Parkinsonism. Another challenge to the diagnosis of true Parkinson's disease may be the presence of recurring mini-strokes. These small strokes are the primary cause of vascular Parkinsonism, which is due to problems of the vessels of the brain regions that control our movement. People with vascular Parkinsonism often experience lower body Parkinsonism and have trouble with walking and balance that resembles classic Parkinson's disease. Generally, people with vascular Parkinsonism are less likely to have the tremor of Parkinson's disease. A sudden massive stroke would not likely be confused with Parkinson's disease because, unlike Parkinson's, massive stroke symptoms would arrive suddenly. However, repetitious mini-strokes may gradually produce Parkinsonism as well as dementia. If mini-strokes are misdiagnosed and treated with medications typically used for Parkinson's disease, the illness on display will not be treated effectively. When in doubt, it has become best practice to complete an MRI procedure and more effectively rule out the presence of any vascular brain infarct, also known as mini-strokes. Another cause of Parkinsonism, rather than Parkinson's disease, may be head trauma. For example, athletes who engage in combative sports like boxing, martial arts, and football are at significant risk for repeated blows to their head. The repetition of the blows often results in small hemorrhages in brain areas that control movement and thinking. Diagnosticians must anticipate this cause for Parkinson's-like symptoms and not mistakenly diagnose the traumatic injury as Parkinson's disease. Beneficially to diagnostic process, the region of the brain that produces dopamine is located deep in the brain, and thus is very hard to injure, even by blows to the head. Therefore, despite its resemblance to classic Parkinson's disease, this Parkinsonism caused by head trauma is not Parkinson's disease. Scientists are also exploring the idea that loss of cells in other areas of the brain and body contribute to Parkinson's disease. For example, researchers have discovered that the hallmark sign of Parkinson's disease, that is the clumps of protein, alpha-synuclein, which are also called Lewy bodies, are found not only in the midbrain, but also in the brain stem and in the olfactory bulb of the brain. These areas of the brain correlate to non-motor functions such as our sense of smell and our sleep regulation. The presence of Lewy bodies in these areas could explain the non-motor symptoms that people experience with PD before any motor sign of the disease even appears. The intestines also have dopamine cells that generate in Parkinson's disease, and this may be important in the gastrointestinal symptoms that are part of Parkinson's disease. The progression of Parkinson's disease varies among different individuals. Parkinson's is chronic and slowly progressive, meaning that symptoms continue and worsen over a period of years. Parkinson's is not considered a fatal disease, and the way that it progresses is different for everyone. Movement symptoms vary from person to person, and so does the rate at which they progress. Some are more bothered than others, depending on what a person normally does during the day. Some people with Parkinson's live with mild symptoms for many years, whereas others develop movement difficulties rather quickly. Non-motor symptoms are very individualized, and they affect most people with Parkinson's at all stages of the disease. Some people with Parkinson's find that symptoms such as depression or fatigue interfere more with daily life than the problems with movement. I want to give you some descriptions of mild, moderate, and advanced Parkinson's to help frame all of this that I've shared with you about the symptoms. In mild Parkinson's, you will see movement symptoms that may be inconvenient but do not affect daily activity. Movement symptoms often like tremors, which occur on one side of the body only. Friends might notice changes in a person's posture, walking ability, or facial expressions. Parkinson's medications suppress movement symptoms rather effectively at this stage. And last, regular exercise improves and maintains mobility, flexibility, range of motion, and balance, and also can reduce depression and constipation in the early stage. In moderate Parkinson's disease, movement symptoms occur on both sides of the body. The body moves more slowly. There's trouble with balance and coordination that develops. Freezing episodes, when the feet feel stuck to the ground, will occur. Parkinson's medications may wear off between doses. Parkinson's medication may cause side effects, like dyskinesia, which is involuntary movements. Regular exercise, perhaps with physical therapy, continues to be very important for good mobility and balance in the moderate stage. And lastly, occupational therapy might provide strategies for maintaining independence at this stage. Now, in advanced Parkinson's disease, great difficulty occurs for walking. In wheelchair or bed most of the day is where clients generally spend their time. They are not able to live alone at this point in their lives. Assistance needed for all daily activities is required. Cognitive problems are prominent, including hallucinations and delusions. And last, balancing the benefit of medication with the side effects of the medication really becomes more challenging. At all stages of Parkinson's, effective therapies are available to ease symptom and make it possible for people with Parkinson's to live well. There are many medications available to treat the symptoms of Parkinson's, although none yet that actually reverse the effects of the disease. It's common for people with Parkinson's disease to take a variety of these medications all at once. But they take them at all different doses and at all different times of the day. And this is the best way to manage the symptoms of the disease. While keeping track of medication can be challenging, understanding the medications and sticking to a schedule will provide the greatest benefit for the drugs and avoid unpleasant off periods due to missed doses. Although nutritional supplements have shown some promising results in preliminary study, it's important to remember that there is not sufficient scientific data to recommend them for Parkinson's disease. Over-the-counter medication can and do have side effects and interactions with other drugs. They tend to be expensive and they vary with different manufacturers. Before taking any over-the-counter medication, it's very important that a person with Parkinson's disease have a discussion about the addition of these supplements with their doctor. And currently there are only 2 surgical treatments available for people living with Parkinson's disease. They can have deep brain stimulation and surgery performed to insert a tube in the small intestine, which delivers a gel formulation of carbidopa-levodopa. Those are the 2 primary drugs to use to treat Parkinson's disease. Brain stimulation is certainly the most important therapeutic advancement since the development of levodopa. It is most effective for individuals who experience disabling tremors, wearing off spells, and medication-induced dyskinesias, with studies showing benefits lasting up to 5 years. That said, it is not a cure, and it does not slow the Parkinson's disease progression. It is also not right for every single person who has Parkinson's disease. Like all brain surgeries, deep brain stimulation carries a small risk of infection, possible stroke, bleeding, or even seizures. Deep brain stimulation surgery may be associated with reduced clarity of speech. And a small number of people with Parkinson's disease have experienced cognitive decline after having this type of deep stimulation surgery. It's very important that a person with PD who is thinking of having this surgery be informed about the procedure and have realistic expectations about it. Duopa, which is the drug that I described above, the combination of carbidopa and levodopa, uses the same active ingredients as orally administered carbidopa levodopa, but it is designed to improve absorption and reduce off times by delivering the drug directly into the small intestine. Like any surgery, the procedure carries risks along with the use of the device that delivers the drug. These include movement or dislocation of the tube, infection, redness at the insertion point, pancreatitis, bleeding in the intestine, air or infection in the abdominal cavity, and failure of the pump. The drug may also lead to side effects, and the drug is contraindicated for those taking non-selective Mayo inhibitors. So, more than 10 million people worldwide are living with Parkinson's disease. As many as 1 million Americans live with Parkinson's disease, which is more than the combined number of people diagnosed with multiple sclerosis, muscular dystrophy, and Lou Gehrig's disease. Approximately 60,000 Americans are diagnosed with Parkinson's disease each year, and this number does not reflect thousands of cases that never are detected. Incidence of Parkinson's disease increases with age, but an estimated 4% of people with Parkinson's disease are diagnosed before the age of 50. And men are 1.5 times more likely to have Parkinson's disease than women. The combined direct and indirect cost of Parkinson's, including treatment, Social Security payment, and lost income from the inability to work, is estimated to be nearly $25 billion per year in the United States alone. Medication costs for an individual person with Parkinson's disease averages $2,500 a year, and therapeutic surgery can cost up to $100,000 per patient. Needless to say, perhaps, it seems evident that at some time during a caregiving career, you may share the challenges of assisting a person afflicted with Parkinson's disease or Parkinson's-like symptoms. I remind you, be patient, attentive to safety, encouraging without demand, conscientious about prompting the affected person to keep a medication regimen accurate and timely. In the end, your capacity to understand the trial of Parkinson's disease and Parkinsonism and to compassionately support this person in your care will be valuable assets to your client. Thanks for listening today, and remember, if you are a TLC employee, report your attendance to me for proper credit in your employee record, and employee or not, I encourage you to continue using TLC Academy.